Hello, I am Fred Trotter. I'm a healthcare data journalist, and I am streaming from Health Data Palooza. Um, I have Mark Scrimshire with me here today, and Mark is a longtime health IT expert, has been someone who I could reliably ask really hard questions to, not just in the current technical paradigm for the last 3 or 4. He is a walking gallery member. So we do have Regina Holiday here painting, and we had a walking gallery meetup last night at the reception for Health Data Palooza, and he was there. So, Mark, could you introduce yourself?
Yeah, certainly. Mark Scrimshire, Chief Interoperability Officer here at Onyx. So we're a 4-year-old startup spun out of our parent company that's been doing work for CMS for 20 odd years. And what we've basically done is take the work that I did at CMS with Blue Button and the Blue Button API and build a platform for FHIR interoperability, primarily for payors. And so that we've been able to supply the APIs that payors need to provide to patients and their members to meet the original CMS interoperability rule that went into effect in 21. And obviously now CMS this year in February released their latest prior authorization rule that takes FHIR and applies it to the provider and the payer-to-payer world, as well as enhancing the data for patients. And that's going to automate the prior authorization process, which everybody claims is a pain. And it will actually lead to much more data flow to patients by virtue of them having to release that information. So we're busy building out that platform for all of our clients and for a lot of new clients. And I'm actually retained by HL7 to write one of the implementation guides, the Payer Data Exchange implementation guide, that is actually named in the CMS regulations.
So you just skimmed over 20 years of health interoperability and healthcare open data principles. So for the listeners who might not know, the Blue Button is a long storied process, and that I can't remember who was the person who said it on stage, but it's the first time that a president of the United States mentioned a graphical user interface design. But someone said, why isn't it easy for patients to get data?
And actually, if you can see this on the video, this actually has a blue button, and this was painted back in 2010 by Regina. So
that's a beautifully faded blue button, and
yes,
I think it's marvelous that you still have that.
Yeah.
But the idea was this is supposed to be easy, and there was an age where you could, and to not use the fact that the data wasn't ready and that we didn't have formats as excuses for not downloading it. So the Blue Button, the idea of Blue Button, since its inception, has been this really radical cool patient data access rights phenomenon. So every time you hear someone talking about Blue Button, to varying degrees, it has always had that idea inside. Let's not wait. Let's do what we can do now, even as the underlying standards have changed. And how have the underlying standards changed?
Well, let's see what we're going to see in the next couple of years as this latest rule goes into play. Is we're already seeing the work that the ONC or the ASTP is doing to move forward the standards for clinical data, expanding the amount of data that's there. But this latest prior authorization rule from CMS is going to make it easier for providers to query a payer to say, do I need a prior auth? And if so, what data do you want so you can make the decision, right? What CMS has also done with that is saying, well, if you're making that decision and communicating that back to the provider that requested it, you also need to make that data available to other providers that may be treating that member and the member themselves, not just the prior authorization decision, but the clinical data that was requested to support the decision. So we're going to see far more data start to flow through these APIs. So they're going to be augmented from what's there today.
So explain So first of all, this is a case where it's one of these really deep technical issues, and I want to encourage our listeners. It may seem unimportant to talk about these kind of data standards, but if the patients are not involved in the data standards, if they're not, willing to kind of wrestle with these details and coordinate with technical people like Mark to make these things happen, then we end up having systems that don't work for us. So I think it's really exciting, and I think you do the best job of anybody I know. I know because you're the one who does it for me to kind of translate the geek speak into something. So tell me, we keep saying this word FHIR. What is that word? Where does it come from? Why is it important?
Okay, so FHIR, it's a fast healthcare interoperability resource. It's a specification. It's been around for 12 years. It was Graham Grieve and a couple of other folks got together in the HL7 organization, and I treat it as it was a reset of HL7's specifications. Version 2's been around for 50 years now.
Yeah, and just to let people know, HL7 is a standards body that does health information standards. And HL7 version 2 is still used regularly to move lab data around. HL7 version 3 was an XML standard that never really took off.
It was too complicated.
So
the way I view it, and Graham may tell it in a different ways, that it was really a reset of saying, look, there's this thing called the internet out there where they do things in relatively simple ways, but we've proven that they work at scale. Why don't we use that technology? And so the specification, in effect, actually specifies itself, because you have these resources that define what resources look like. So it's literally a specification that you use to specify the specification and the use cases. And the real secret to FHIR is it's not the base specification. Yes, that's great. It's the use cases, or as we would say in the business, the implementation guides, which is where a community has got together and said, if we're going to exchange data, we need to understand what we're saying to each other. And so the specification, the implementation guide, will tighten up the specifications to, for example, in the US, say, if you're going to send us information about a procedure or a service, use an ICD-10 code, so an international standard code, right? Or use a CPT code, another standardized code set, so that we start to understand what we're talking about, rather than have to try and interpret something in a handwritten clinical note, right? That's the real power of FHIR, in that is increasingly done using standard formats we see on the internet, like JSON. It can use XML, but most people are around using JSON these days. And the secret then is that you then have standardized ways of obtaining data. So what Blue Button did was, me being lazy, saying, well, why invent my own API and my own data formats when there's something out there? And the advantage of that has been that developers, actually, the latest CMS Connectathon in July, I was running a track for Payer Data Exchange, and a first-time attendee came along, and within 30 minutes, he was actually interacting with one of the APIs, testing out data, right? It's that familiar that you're dealing with stuff that if you've coded to write an app for Facebook or LinkedIn,
it's REST,
it's
JSON.
Yes, it's REST, it's JSON. So it's very easy to get started, but it can get complex, right? But the implementation guides start to set the boundaries for what you're dealing with. So what's happened with Blue Button, the reason I think Blue Button has been as successful as it is that it's very easy for application developers to come along, go knocking on the door of CMS, go into the developer portal, get a set of credentials, work with their sandbox, test out their app, and then go through an approval process to get connected. Now, for the member or the beneficiary, it's really simple. They use that app. If you've got, Apple Health or whatever, MyChart on your phone, you'll pick out your particular provider, and there'll be a standard API that you can now get your patient data, right? Blue Button's done the same thing in the payer world, right? So what we saw when there was real adoption of Blue Button is that for many of the solutions out there using CMS Blue Button data, the beneficiaries coming in choosing to share their data with a particular app, but they're not actually seeing the data. For example, one of the most popular ways is take a look at all that claims data, and a payer could say, if you're looking for a Medicare Advantage plan, this is the best plan for you based upon your claims history. You don't need to work through, the 100 claims you had last year. That's the benefit it really brings, is that it's really down to what works for you as a patient or as a member in the apps that are out there. So at Onyx, we've delivered this for a number of payers and a number of Medicaid state agencies, where there's a whole host of application developers out there that are connecting their apps to provide this access to data. So the member or the beneficiary, it's simple. They can go and look up their claims. They can see provider directories. They can see their drug formularies. They can do all of that, and it can be presented in a user-friendly way by the app. The hard part is for the developer to get over that hump of getting connected to the APIs.
So can you explain what TEFCA is? People have started using that phrase like, I think in a kind of Band-Aid way, where they're saying a lot. I mean, TEFCA used to be just the agreement. Now it really means
It's
more than
turning
the
into
agreement.
something real. Yes.
The implications of having made the agreement, I mean, there's a lot more there. What do you see TEFCA meaning? And by the way, like, just again for our audience, like the kind of data flow that we're talking about here is for if you're a video game developer or you are working on the regular internet, it must sound so mundane. But what we have been looking for years in healthcare is the real reason why we have not had healthcare exchange to the benefit of patients has usually been political and resource problems, and it's been very profitable to hoard data and to silo data. And so, but they were always dressed as, well, we don't have any standards, we don't have any. So we in the technology community for health information exchange have really been looking for solutions that would allow us to at least expose the fact that people were hoarding data. And there was some law passed about information blocking, and TEFCA seems to be kind of the silver bullet that's going to solve that problem, kind of. What do you think?
I don't want to get on Mickey Tripathi's, bad side, but you could say at the moment, TEFCA is an aspiration, right? The objective is that we'll have some agreements that's going to allow data to flow where it needs to across the healthcare ecosystem in the US, right? And, if I bring it back to, well, what have I been doing? I describe part of my job in writing some of these specifications, like provider access, is I'm creating the next generation of problems to solve, right? When you look back at what was done with the interoperability rule, the API exchange of data is pretty simple and straightforward, predictable for a lot of developers, right? But getting connected to that secure API is a whole host of hoops that you have to jump through with the particular payer, and everyone will do something subtly different. So there's no standardized way of doing it. When you look at the prior authorization rule from CMS, where they're expecting millions of providers to talk to thousands of payers to say, do I need a prior auth? That process of getting connected to that payer's API to be able to ask that question, if we do it the way we did for the interoperability rule, is absolutely not going to work. We have to have a framework where I can discover where I need to go, so the discoverability of endpoints, and then I have to have a standardized way where I can say, I am who I say I am, and you know that, and therefore give me access because I've got the right approvals from some sort of notional body, we call it TEFCA, that says I'm allowed to do this, and therefore I can automatically get a set of credentials to talk to your API. That's what we've got to solve. with TEFCA, right? And that's the aspirational part that we're all working on to try and solve. And what's happening at the moment is things like Commonwell and other organizations, that some of the HIEs, we're really working to use those legal frameworks to at least prove that we can do some of these exchanges at scale.
So I think there has been a lot of TEFCA drama, and there's been, which have reached the mainstream news, normal news now. So I think in some senses, and by the way, when you say Mikitrabathi is the current ONC, and that has changed.
ASTP.
What is it? The acronym?
ASTP.
ASTP. So what used to be the Office of National Coordinator has been promoted into being a more formal role at HHS, which I really applaud. That's incredible news. And then the Mikitrabathi is the person who's the current ONC and is going to take this new role as well. And I'm really thrilled about that. I think what is amazing is, and I think he'll probably get a bunch of heat and attention for the TEFCA going right or wrong or not, being smooth. Those were inevitable problems. Yeah, and in some senses, when you get everybody to sign on the dotted line and say, we're going to start exchanging data, if you don't have drama, you're really not exchanging data.
Yeah.
Because the different expectations that people have about data flowing, like, it's going to make people upset. And so I think my grandfather told me, I remember very, very clearly, I got into more than one college and I was accepted to go to 2 different or 3 different colleges or something. And he called me and he said, Fred, this is a good problem. You got to choose which college you're going to go to. Not everybody gets to go to college. You've got a good problem. And that's how I think about the dramas of TEFCA, right? It's like, these are the problems that you have when the data flows.
Yeah.
Oh my God, the data's flowing, right? That's the big takeaway for me. So I think these kind of real problems are really, really exciting.
Yeah.
Tell me now briefly, we wanted to have a relatively quick call here, a conversation. And you and I literally have talked for hours in the past about this stuff. But when there's a kind of a natural a life cycle for the FHIR standard to grow and get to the next level, and it starts with one group agreeing on what the next standard is going to be, and then CMS kind of puts a stamp on it and says, we're going to pay for people who are doing this or not pay if people are not doing this, depending on how they're feeling in that that decade. And then you have these connect-a-thon events, which practically speaking are where these both the really new stuff happens, but also the community grows and the places. Can you kind of take me through that journey around the standards and how and do it from, if you don't mind, from the perspective of someone who is a developer who wants to write an app that's a healthcare app, and they're unfortunate that when they look at the current FHIR standards, what they want to do is not yet covered, but there's a group that's already formed to work on that. It's unapproved. What's the story now? What happens in that scenario?
That's I think the beauty and the power of the FHIR specification. It's really the power of the community. I've been at events where sort of connect-a-thon where folks will actually get together and say, we have a problem, and maybe just start with whiteboarding what that solution might be. And before you know it, somebody said, well, I can put some data into a FHIR server and we can try just querying that, using whatever tool, Postman, whatever, or sit down and write a Python program or something. And it can start as simply as that. I mean, an example, at Onyx, we produced a version of the Karen Alliance's digital insurance card, okay? And for grins, really, at one of the connect-a-thons, I was talking with some folks that are on the PASSIO project. So they're talking about long-term care and advanced directives. And so I went in and I produced a variation of an implementation guide and said, we could add a link in the digital insurance card to where you save your advanced directive. And, that sort of got tied up in, let's do that. That's a great demo. As imagine you're going into a long-term care facility, you're being onboarded there, and you're able to hand over your insurance card, but it might be something on your phone, right? And there's a link so that they immediately know you've got an advance directive, right? And that's the power of the community, is that whereas a lot of specifications are sort of defined in the ivory tower and pushed down, the FHIR is largely, it's grown up around the community, and the community lifts it up. And then you've got all the standards processes. So I'm currently putting the Payer Data Exchange IG through the ballot process, and I'm going to have a boatload of tickets that I'm going to have to review that we have to resolve in community meetings, right? So there's that side of it that can slow things down, but you can experiment with FHIR, right? Playing with FHIR, that's a good one, isn't it? So, and like I said, Connectathon had somebody come along this time, first time round, and they very quickly, within 30 minutes, were interacting with a FHIR server and saying, oh, I can see, what this data can do. So you can do that. The beauty of the Connectathons is a lot of people feel afraid of, I don't have a polished application. It's not about that. Come along, use Postman, use Insomnia, whatever app you're comfortable with. Sit down and write some Python if you want to, or JavaScript. You can do that and interact. And I remember a friend of mine a number of years ago said the other side of this said, I've been trying to get our team together with some of these EMR vendors, and decided to bring them along to the Connectathon, and said, look, there they are. They're sitting down side by side with the developers from the EMR vendors, where, they're now connected. And that's the power. And the folks like Graham and Lloyd McKenzie, Ewert Kramer from Pilot, some of the key people in the FHIR movement that are really driving the core specification. They're sitting there in the room, coding stuff the same as we are, and you can literally, we've got this problem, and you can walk across the room. I mean, we're talking 350 geeks in a room for a weekend, right? And you can ask a question of somebody that's been bedded in FHIR for 10 years or more and get an answer. That's sort of the power of the community. And then the tools around it, like Zulip or chat.fire.org, where you can be interacting with these folks over the wire.
And then the wonderful thing is that community then coalesces. They have the ballot. It becomes official part of the standard. The standard is generally ahead of what is mandated by a couple of versions. And then CMS comes out and says, okay, well, this is now old and stable and people have been using it. Now that's part of what's required for health information.
Well,
so
CMS is taking
right?
slightly different approach there. ONC with their HTI rules are really moving towards, let's certify and we'll have a specific version, but they've got what they call
we're talking about certification. We're talking about the certification of electronic healthcare records that a doctor or hospital will use in their environment. And that dictates the capabilities that the health information system across the healthcare system is basically dictated by the certification level of these software. Yeah. And then CMS still pays for or doesn't pay when you don't have any EHR. I can't remember exactly where they are.
CMS really covers the payer community. So if you look at their regulated plans, you've got Medicare Advantage, you've got Medicaid, you've got Children's Health Insurance, and you've got the qualified health plans on the federal exchanges.
ACOs.
That's where they spend money, right? So because they spend money, they have the power to say, you are expected to do these things. So they can then write these rules. And what they've been doing is saying, we're not requiring particular implementation guides. They may have the base standard, FHIR 4, yes, required, right? But the implementation guides, they're saying these are recommended. But like I said, I've been in no end of joint webinars with folks from CMS. Read the tea leaves. When they say recommended, read the tea leaves. They really are strongly recommending, because we all recognize that these implementation guides are not going to be static, particularly over the next 2 years. We are going to need to learn from implementation and make changes. And if you've locked in an implementation guide at a specific version in regulation, you sort of killed somewhat future development.
Yeah, so
right?
trying to be flexible.
So it's giving that level of flexibility. That's where the ONC or ASTP with their SFAT process is a way of grading the specification on an annual basis. So they're gradually expanding the coverage.
Of course, as a patient advocate, I would say, we should have the highest good version, and that should be the only thing that's incentivized. But as a policy wonk, I know that what you're talking about, the process you're describing, is a very subtle and nuanced policy approach that is really doing quite a slalom down the hill and hitting a lot of points that it needs to about making sure there's not unintended consequences, making sure things are happening. So, and more importantly, what we're describing here is the operating system of the internet generally is being slowly adopted into healthcare and will then operate as an internet for healthcare. And then once we have that, we're going to be, we're going to have more good problems, right? Yeah. In some senses, the problem of how you handle privacy on a platform like that is part of the privilege of having a platform like that.
Yeah.
So it's really, really exciting. Thank you for all the contributions. Just so you know, I think of you as one of the giants of FHIR and one of these people who you go to the Connect-a-thon to meet. And if you're a developer looking to get into this space, or you're a patient and you want your features prioritized, go to one of these FHIR Connect-a-thons. I think they're amazing. Thank you for the work, and thank you for being interviewed, Mark. I really appreciate it.
Appreciate it. It's always fun to chat with you, Fred. You've been an inspiration for years as well. So,
well, thank you for phrasing it as an inspiration as opposed to a gadfly. I really appreciate that. I definitely prefer to be known as an inspiration. So,
thanks a lot.